Okay, let's get started. Good evening, everyone. Gives me great pleasure to welcome you all to the third edition of the dialogue series on primary healthcare, an initiative by the Center for Primary Healthcare at BHS and the Center for Healthcare at IIM Udaipur. We thank all those who have been attending this webinar series and welcome those who are joining us for the first time. Basic Healthcare Services, BHS, is a not-for-profit organization which is driven by the vision of enabling marginalized and vulnerable communities to lead a healthy life with dignity. Through a network of primary healthcare clinics, BHS provides healthcare to rural and tribal populations in the district of Salumbar and Udaipur in southern Rajasthan. The Center for Primary Healthcare at BHS is set up with a vision to generate and disseminate knowledge, tools, and technology to design, implement, and evaluate primary healthcare services for the marginalized. The Center for Healthcare at IIM Udaipur focuses on healthcare-related research using a management lens. The center acts as a platform for researchers, practitioners, policymakers, and other stakeholders to come together to create evidence-based impact. The Center for Healthcare is currently prioritizing research in the primary healthcare space. The Dialogues on Primary Healthcare is a series discourse on practice and policy of primary healthcare in India. While there is a reasonable evidence that health systems founded on strong primary healthcare are effective, resilient, and cost-effective, there are not adequate understanding of how to design and build such systems. So the dialogue series on primary healthcare is designed to bring out such a conversation. The first episode of the series presented a conversation with Dr. Ritika Khera and Dr. Sudhaman Ramani, who discussed the evolution, current status, and future directions of publicly delivered primary healthcare in India. In the second episode, we had Dr. Radhika Gore and Dr. Priya Das, who dwelled into socio-cultural, political, and bureaucratic dynamics that affects the providers within a primary healthcare setting. Today, in the third episode, we have two speakers who are going to unravel the intricacies of public-private partnership in primary healthcare. With that, I request Dr. Pavitra Mohan to introduce today's topic and today's speakers. Over to you, Dr. Pavitra.
Thank you, Veda, and welcome all the panelists and the audience. So, there is this saying which says that if you want to go far, go with others. If you want to go fast, go alone. So, partnerships in healthcare are imperative. I mean, there's no question whether you need partnerships or not. It's something that is critical. There's no denial of the fact, nor does anyone contest it. But what is contestable is that how do you make these partnerships work? While the government has the mandate and the resources to provide primary healthcare to all the population, especially to the most marginalized, it may fall short of doing so either because of resources, manpower, ability to reach the last mile, understand the intricacies of delivering healthcare to the last mile populations. On the other hand, the private and non-governmental actors may understand the communities better. They may have the technology and the tools and the experience to work with the last mile communities, have the expertise that is required to deliver healthcare. But often the two don't work very well together. That has been the experience largely. And I'm very happy that today we have two very strong kind of insights coming from very different sources. The one is the real experience of actually delivering primary healthcare in partnership with the government for a long number of years. Karuna Trust is the largest, probably in the world, but definitely in India, the most widest and the long-standing experience of delivering primary healthcare in partnership with the government in the state of Karnataka, as well as in several other states, including the difficult-to-reach areas of northeast of India. Tuberculosis program is one which kind of boasts of a strong private partnership of a government program to deliver an objective of eliminating tuberculosis from India. realizing that a large number of people seek healthcare from the private sector when they are ill, especially with diseases like tuberculosis. But whether that partnership works, what are the determinants of it? That is the experience, and especially the evidence that Dr. Rakesh brings in from the union, trying to understand that what are the factors that really affect the success or not of public-private partnerships in case of. So he along with his colleagues performed a review of evidence of what factors enable or inhibit or impede the success of public-private partnership in tuberculosis elimination across several states and across different initiatives. So I'm very happy to welcome Dr. Rakesh, the first speaker for the day, who would share his both. So interestingly, Dr. Rakesh is a public health physician and a researcher. So he's not a researcher who works out of ivory towers. He dirties his hands and has worked extensively in eliminating tuberculosis across large geographies, but at the same time has also conducted a very significant recent research where he tried to understand the factors around the public-private partnerships in TB elimination. So with those, I'll invite Dr. Rakesh to start his presentation and share some of his findings and insights on these partnerships around tuberculosis. So over to you, Dr. Rakesh.
Yeah, thank you so much for these kind words and inviting me for discussing a very important topic today. I'll try to share my screen and try to present the recent research which Dr. Pavitra was mentioning about. I hope my screen is visible. Yeah. So this is basically a systematic review and meta-synthesis of qualitative research on facilitators and barriers for private health sector engagement for TB care in India. So this has recently been published in Global Health Science and Practice. We all know that India is the country which is reporting largest number of tuberculosis cases, approximately around 28 lakhs new TB cases in a year. And all the recent studies, including the drug survey data, the National TB Prevalence Survey data, all these have shown that more than 50% of the people with TB symptoms, they seek care from private sector. There are lots of studies that happen which has actually documented some concerns about lack of systems for treatment adherence and a high loss to follow-up rate among TB patients, especially starting from Mumbai. So there was a felt need from the program itself, like the National TB Elimination Program, to ensure that private sector is engaged on a scale to achieve the universal access to tuberculosis care. So this was basically the vision. The vision of the National Tuberculosis Elimination Program has been rightly put in the National Strategic Plan as everybody should be able to, every citizen of India should be able to get the standards of TB care according to the provider of his or her choice. So this was basically the vision that has been mentioned. The program is actually trying to attain that over the last 2 decades through various interventions, not going into details of all those interventions. So the program is trying to engage all sorts of providers through various interventions. If you look at the National Strategic Plan, the standards of TB care in India has been brought as a set of standards to ensure that every citizen reaching a sector, any hospital will receive the care according to their choice. So basically, these are all some of the benchmarks that has been created irrespective of the facility, private sector or public sector, where the citizens are actually reaching. Some regulatory measures have been taken by the government, including mandatory TB notification, some Schedule H1 regulations in terms of prescription of the anti-TB drugs and all. There has been lots of initiatives for extension of the public provision of the services in terms of offering free drugs, free diagnostics through agencies like PPSA, like private provider support agencies. Offering the public health actions for all the notified TB cases, initiatives like training, capacity building. So there have been huge amount of money that has been earmarked for engaging the private sector in general by the National TB Program. On the other hand, there are provisions for strategic purchase of services from the private sector through the National Partnership Guidelines of 2019. So I just wanted to say that all these measures are in place, but again, the engagement is considered to be suboptimal. So basically, what we attempted is to look at what does the qualitative research tell us about the barriers and facilitators for engaging the private health delivery sector for TB care in India. So this was the question that we tried to ask. What we have done is a systematic review and a meta-synthesis. Meta-synthesis is basically it's combining all the qualitative insights from the multiple studies that has already been happened with related to this particular topic. We defined the private sector engagement for the purpose of this study as meaningful inclusion of the private providers, especially in a mixed health systems. This is exactly the definition used by the WHO advisory group on the governance. So this definition is a very broad. So this captures even the informal collaborations to the most formal sorts of partnerships, basically. I'm not going much into the methods basically because we will spend some time on discussing the results. So basically, all the qualitative studies that were included, perspectives of which capture the perspectives of the private providers or the program managers or some intermediary agencies who are working between the government and private for getting things done. So all the perspectives, like the studies documenting whose our perspectives we have tried to include in that. We generally focused on for-profit healthcare sectors because the problem was basically there. So we generally focused on the for-profit private healthcare sector, including both formal and informal providers. We included only the health service delivery providers and not other forms of providers like manufacturers. What we have done is a typical systematic review methods, but we also used a quality assessment using a CASP initial CASP protocol and a grade analysis. So basically, whenever we provide evidences, we try to build in evidences in terms of confidence in the evidence from the review of qualitative research. So there is a grade approach that we have actually tried to put into say, what is the certainty of that, basically that finding is on. We used a systematic search strategy to search the entire literatures, including whatever is being available, citation chaining, all these sort of stuff. And finally, starting with 267 from the database research through inclusion-exclusion criteria, we finally ended up in analyzing 19 studies done in India with related to this particular topic. With related to the 19 studies included, most of the studies were done in recent 5 years. It captured perspectives of most of the studies captured perspectives of the doctors basically, and used multiple methods during that. And noticeably, most of the studies were from southern part of the India. There were lack of studies with related to this from the northern part of India. 6 studies were from Karnataka itself, 4 from Kerala, 2 from Maharashtra, and 1 each from Himachal, Telangana, Gujarat, Kolkata, and Bihar. So these were the studies that were actually included in this analysis. Altogether, put together, these 19 studies had 31 focus group discussions with multiple providers and 303 in-depth interviews. In-depth interviews were with multiple, including NTP program personnel like program managers or the modern medicine practitioners, all these group of people, right? So these were the summary of thing. And this is how we try to use the grade circle approach for grading the evidences. So grading of the evidences was based on looking at the methodological limitations of the included studies, coherence of the review finding. If all the studies are citing the same finding, yes, obviously, yes. If there are conflict between the studies, then the evidence grade will go down a bit. So based on all these criteria, we try to grade these evidences generally. And what came as findings, basically, many themes emerged from the studies. And one of the themes is basically the context in which the engagement occurs. And our findings were basically that. Finding number 1 is the private health sector is actually willing to collaborate. So basically, they consider it as their responsibility to collaborate. So there are many anecdotal evidences, many experiences which says that private sector is willing to collaborate and they consider it as their responsibility to collaborate also. However, the private sector had lots of concerns, and most of these concerns were basically based on experiences, previous experiences or prior experiences, including losing the businesses. Fine. Collaboration means private sector should not end up in losing their businesses. or they should not end up in a fear of scrutiny of some kind of steps or unnecessary. I mean, they had their concerns that there will be unnecessary. They will lose their autonomy to prescribe even what they feel right for the patient. So there were lots of concerns as far as private sector had concerns while collaborating with the government, but generally they were all really willing to collaborate. One of the biggest concern was about the patient's confidentiality because TB notification is a mandatory thing. So private sector, I mean, by rule, they all are able to notify all forms of tuberculosis. But one of their major concerns was about keeping the patient's confidentiality. Once they notify, many of the patients, they came back to them and complained that their privacy was not maintained. Many people went in search for, I mean, they came to the home in search of them. Confidentiality breach was noticed. So this was one of the major concerns by the private provider as far as TB notification is generally concerned about. So they say that patients generally tell them not to notify to the government because my daughter is getting married. It's her marriage age. If they come to know that, I mean, there are lots of sort of confidentiality issues with the patients used to highlight to the private providers as reported by the private providers generally. Another important finding is basically, as far as TB care is concerned, this is, I mean, when we talk about private sector, it ranges from a lot of for-profit private sector itself. Private providers ranges from the indigenous providers to the chemist to the Ayush providers to the individual practitioners to the corporate hospitals. So there is a wide range of providers basically as far as private sector is generally concerned. But as far as hospitals are concerned, when management is taken into consideration, some of the engagement activities were really better. And when there was a single window systems within hospitals, especially hospitals are concerned, some of the things were actually, it was a facilitator basically. When the management is on board, the entire hospital can have a single window mechanisms and helps that actually helps in patients or the clients getting the standards of care which they deserve, including collaborations with the government, getting the drugs, getting the diagnostics, everything was possible. Private sector also felt that the program is actually demanding too much of patient-wise data. They felt that we don't have that much time to spend on handing over all these informations. There need to be an information, there need to be simplified mechanisms for information exchange generally. And they said that too much of data is collected, which they really don't know why this data is being collected, honestly speaking. The important evidence with high confidence of evidence was basically there is a lack of coordination mechanisms. There is no dialogues generally happening between private and the public. Most of the decisions were taken, the entire PPP is envisioned from the lens of the program generally, where there are not much consultations that happened with the private sector. And there is a lack of coordination mechanisms. There is no mechanisms for dialogue. There is no place where they can actually exchange their views generally as far as private sector engagement is concerned. So this was reported in most of the studies as a major barrier for the private sector engagement, a lack of coordination mechanisms. With related to incentives, like government used to provide lots of incentives generally. For example, if you notify a case of TB, government used to provide 500 rupees as an incentive to the private provider. With related to the incentives, the studies had contrasting findings, but most of the studies reported that the motivation to engage, it was not driven by the financial incentive that the government is actually providing. But this might work for, say, for example, engaging informal healthcare providers or the chemist generally, but if provided timely. Most of the times what has been observed is that there is a delay in the disbursement of the committed funds. It is very common, especially in terms of partnership schemes. Many private hospitals, they started laboratories based on the RNTCP program. They entered into an agreement as on MOU, but most of the times what happens is that there is a delay in the disbursement of the committed funds generally. And this generally could lead to the loss of trust among the partners. So this is one of the important concerns that the private sector generally raised. And even the program managers, they even prioritized, they deprioritized whenever there is a shortage of funds, they deprioritize giving funds to the private sector. Another important thing which the all private sector providers in all the studies generally reported was like, they really wanted them to be equal partners, basically, right? Most of the times what happens is it's like a relationship is basically a kind of authoritarian approach by the government, but there was not even like they were not involved even in the planning phase, not even involving in the other phases. So generally they consider that these non-financial incentives like recognition, providing right feedback to them, involving them in the planning and review, and giving equal status in the partnership. That itself was, many providers said that that itself is enough for the private sector to contribute to the fight against tuberculosis, basically. But this was generally reported as lacking and found as a major barrier for engagement. There are also findings which said that NTP staff generally lack the capacity to deal with the private sector, because whenever there is a NTP staff goes to a busy private hospitals, they won't be able to even talk to the doctor. They won't be able to address the technical queries raised by the doctor. So all these sorts of stuffs are there. Lack of uniform understanding among the program managers. For example, there will be a good program manager now, everything will go smooth. Next, another program manager comes, then everything will go in the other way. So basically, it all depends on the individuals, basically, and there was no institutional mechanisms or uniform understanding among the program managers. That actually they reported as a major barrier, basically. Another important feature is about the lack of systems for regular updates, programmatic aspects, not the clinical aspects or anything, but about the programmatic aspects in the private sector. Another important feature that came out, I already mentioned, is the authoritarian approach of the district officials with related to the partnerships. Basically, they said that partnership means it should be partnership. It means both the partners are equal. But many times they never felt that. They felt that it's a stepmotherly attitude sort of stuff, which many of the private doctors generally highlighted. And sustained interactions generally considered as an successful enabler. There are many enablers generally, especially with related to the good people, good persons who consider them as good partners, persons who generally, the program managers generally consider them as people with giving them equal status. So all these things were considered as powerful enablers, but most of the times it was the barriers that are actually coming into play. So in conclusion, basically, there were many barriers with related to engagement of the private sector. Most of them were with related to the context of the architecture, and important them were among the interaction among the actors. Basically, it contributes to the barriers. Based on the findings with high confidence of evidence, we could say that to further strengthen involvement of all private providers, basically what is required is we need to have policies to protect the patient confidentiality, because that was a major concern which most of the private providers generally. And basically for NTP program managers, there need to be a behavior change communication for changing the outlook. The engaging the private sector is not for the private providers, it's for the society. The public-private partnership is basically when the public and the private sector comes together for the society. So many times it is felt that, okay, we are engaging the private sector for the sake of private sector. No, it's not even for the sake of private sector. It's not even sake for the public sector, but it is for the sake of the society, basically. And for that, the NTP managers need a behavior change communication for an attitude change. They also may need soft skill training while dealing with the private sector. Lots of non-financial incentives need to be promoted, and just considering private sector as an equal partner itself was sufficient for most of the doctors to really engage with them. There is a definite need of a coordination mechanism between the sectors, because there is no mechanisms for general dialogue. One typical example is a private hospital consortium where all the private providers came together. Government was also present, and that actually facilitated dialogues in many of the places. So a coordination mechanism could play a major role, and simplifying the data exchange mechanisms, because private sector is not keen on spending too much time on sharing these sorts of informations. I'll stop here for the time being, and I'll be happy to discuss this further during the discussions time. Thank you so much.
Thank you very much, Dr. Rakesh, for that, I think, beautiful and simple presentation. I think it was very lucid, despite the rigor, the academic rigor that it entailed in identifying and selecting and analyzing. It was presented very simply. It is easy to understand for anyone to, see what the specific barriers and one statement that I'll probably always remember is what you said about that a partnership should be a real partnership, right? I mean, it's as simple as that, right? And there are certain elements of that partnership, which is if it is built on trust, if it is built on equality and mutual respect, and that I think is probably going to stay in my mind, and it's probably very central to any significant public and private partnerships, or any partnerships for that matter. I will now go on to Mr. Venkat Chekuri, who leads Karuna Trust, which is a not-for-profit trust based out of Karnataka, but works in several states in providing healthcare to the most remote, tribal, and inaccessible populations in the country. Mr. Venkat has worked a lot on the issues of tribal health and development, and so he looks at healthcare from a rights perspective, from a development perspective, and has a huge experience of managing these partnerships with the government, coming from a not-for-profit sector. That how does a non-governmental entity engage with the government, with the government organization, which is pretty large in its mandate and scope. So whether those partnerships are equal, how has Karuna Trust managed all these years to forge and sustain these partnerships and bring about a change? I would also kind of request him to share some of his journey around what has changed over years. I mean, we have this unique opportunity to ask and find out from Mr. Venkat and from Karuna Trust to say that over 30 years that Karuna has been involved in managing these partnerships, what has changed over the years, because that might give us an insight into the next part of our webinar, which is to say where does the future lie really for these partnerships. So over to you, Venkat, for your presentation on the journey of Karuna Trust in managing partnerships with government for delivering primary healthcare to the remote inaccessible locations in India. Over to you.
Thank you. Thank you, Pavitra, and thank you, Indian Institute of Management, Udaipur, for inviting me for this webinar to share our experience and our issues that we are undergoing in this partnership. So this is a very long journey of around 30 years, and I'm not sure I'll be able to cover all the aspects of this partnership, and I am not sure whether I'll be able to give justice to the expectations of the the organizers. But I'll try my best to cover all the points. The slide. Yes. The partnership with the government actually started in very organic fashion. It is not a premeditated way of like going to the government saying that we are wanted to partner with you. But this was a need base that it was felt to strengthen the health system at the grassroots level. Then only we'll be able to deliver, because as you know, the country is huge and rural population living remotely and very difficult to reach areas. That is how the whole partnership started with a very big and difficult partner, that is government. And here the Karuna Trust is implementing for the last 30 years. It started in 1996 formally, but before that also we were partnering with the government. I will make my presentation in 4 aspects. Actually, one, the historic perspective, how the whole process started, then how the whole process goes and how the management takes care, and what are the outcomes, and what are the issues, and what are the way forward. This is how I will able to present these 30 years of journey. Next slide. So it all started in BR Hills, that is a very remote, hilly, tribal area, southern part of Karnataka. And this is again very law and order prone areas, hilly, and no electricity, no telephone, no developmental agencies ever entered before we entered. This is how we started. And when there were no...
Sorry, Venkat, I think the slides are not moving with your...
health workers. Oh, slides are not moving?
Yes, they're not moving. Yes, now it's moved.
You're able to see?
Yes. Yes.
Okay. So this is how we started, and when there was no health workers, to go into the last mile, that is in the, like for example, BR Hills is 500 square kilometers wildlife sanctuary where no worker wants to go there. That is the time where we have the semi-literate tribal girls. We have trained them to go into the last mile and deliver the services. In fact, this is one is inspiration for today's ASHA program, the accredited social health activist. The NHM National Health Mission program has come. Some inspiration has taken from this initiative, and there were so remote places where we started going into the people. And then 24 years, Abdul Kalam visited us, and he became our champion to tell the people the difficulties in serving the last mile and delivering the health care to the and rural population. And
Sir Venkat, can you please put your slides on the slideshow mode so that we can
Oh.
see it fully?
sorry, I'm really sorry.
No problem. Thank you.
Yeah. So it was the partnership part actually has started with the very high prevalence of leprosy in Elandur Taluk, that is the foothills of BR Hills. So it was popping up on the leprosy map very prominently in 1987. 21.4 per thousand population is very high prevalence, and that is how the whole work of healthcare started in Karuna Trust. And so started communicable diseases clinic like TB, malaria, and in Alandur Taluk. And Karuna Trust, the 1986, we have founded this center. And that was the time why what we felt there is so much of technology innovation in the urban population, like PET scans, MRAs, all that is available. But in the rural and tribal areas, you don't have even functional laboratories. And we have so much of out-of-pocket expenses. That is the time where that we wanted to manage. And like we also analyze the financing part of primary care, where the expenses spending on the primary healthcare is very low. We spend around 200 rupees per person per annum. This is hugely inadequate for delivering the comprehensive primary health care. And another important aspect which has come before this partnership is quality is a big issue. We were not at all concentrating on quality. It's just providing buildings, equipment, and posting some manpower is the only objective of the government, but not the delivery of the services, quality of the services, and outcome based. And are you analyzing all the outcomes? Why the disease burdens are increasing? Why we still not able to achieve certain targets and certain development goals, SDG especially? And private sector is a big player in healthcare. Like for example, 80% of the outpatient care is done by the private sector today. 50% of the inpatient care is done by private. This is how the whole background for public-private partnership has come. And here there is a misunderstanding about private.
Sorry, Venkat, your slides are not moving with your speech. You're still
Okay.
at slide number 7. I think you move ahead. Yeah, if you could move down. Yeah, the slide that is being shown now is process followed by Karuna Trust. under the PPP model. So maybe you can start from here. And
Yeah. So this is you are able to see this public-private partnership slide. Yeah.
yes.
So in this where there is a lot of confusion today about the word private. A lot of people are now government is having public-private partnership in other sectors where for-profit entities come into the picture and they deliver the services for profit. Same thing, even on corporate people also are partnering with government for profit. So here the public-private partnership that we are mentioning is not for profit, and who, especially NGO sector, which would like to strengthen the health system by filling the gaps in the present existing public healthcare. This is how we started, and the process that Karuna Trust follows is like, we educate with the government, finding out the gaps, and we also have dialogue with the community and also local panchayats, and we also talk to the Jilla Panchayat and Health Ministry, and we finalize the MOU with the government, and this is the more of total management of primary health center, which will be completely under the management with the private partner. And all the assets created with this is being funded by government, whatever the budgetary allocation government has, that is given to the private partner. And annual review process and outcome indicators are being shared with the government. Prior to the taking over PSC from the government, we also do little bit of what we call baseline, and we engage certain institutions like HMR to assess the baseline and record, so that we can measure the outcomes at the later date. So initially, it was started with basically government, the whole process of public-private partnership. 75% of the total budget of the primary health center will be given to the private partner, and the 25% has to be brought by the private partner. But later in Karnataka, it has been shifted to 90% to government. Government provides, and the 10% by the private. And now presently it is 100% is given by the government. But there are so many other costs which are not being covered by, like management cost and training cost and innovation cost. And some states like Arunachal Pradesh, Meghalaya, still they have a model of 90% government contribution and 10% by the private partner. And but we were able to, the present outcome shows that in spite of all the less allocation of money, and we are able to show better health outcomes. And as I told you, the government spends very less amount, that is around 180 to 200 rupees for comprehensive primary health care, which is hugely inadequate to cover the comprehensive primary health care. Presently, Karuna Trust is managing 41 primary health centers, 10-bed ICUs in 150 districts in Karnataka, Manipur, Nagaland, Assam, Sikkim, Meghalaya. This is actually after the COVID, the emergency care public-private partnership has come into place. Today, Guardian also has reported about this initiative. This is a model, very comprehensive primary health care, preventive, promotive, curative, and rehabilitative services are provided in the primary health care. And as Pavitra was mentioning, rights-based approach and community-based preventive care and promotive aspect, mother and child care, communicable diseases, non-communicable diseases, immunization, all that is being covered under this comprehensive care. So this is how one of the primary health center run by Corona Trust looks like. So basically, when you compare between a government-run primary health center and a primary health run by private partner, it looks very, clean, neat, and very functional. The process, as I told you, it is basically advocacy of the government, community requesting private partners to be, take over the primary health center, and the whole process of MOU signing and all that. And generally, infrastructure augmentation in the primary health center is part of the initial stages, because the infrastructure will be inadequate, or maybe very in a different dilapidated condition sometime. So all that is being added by the private partner. And another important aspect is the human resources in the primary health center, all recruited by the private partner, that is Corona Trust, and we train them, we motivate them, we place them. Also, one of the condition which government does not able to implement, what we are able to implement, is that we insist every personnel, the healthcare personnel in the primary health center, to stay in the headquarters. That actually has a huge change. Like, for example, a medical doctor staying in a primary health center 24 hours actually has a lot of impact in the primary health center. Same thing with an A&M and male health worker staying in a sub-center. It has a huge impact. And that we insist on that. We make it mandatory for everybody, whoever is being posted, whichever the place, they have to stay in their place of service. We also motivate them. We also give them training. We also give them supportive supervision. It is like a handhold supervisory service. It is not a policing. Because each healthcare professional will be at different stages of skill, and we are able to their work. And these are the services that we provide 24/7.
Sorry to intervene, but I think we will have only next 3 to 4 minutes to conclude, because
okay, I'll conclude fast. So these are the
services to answer then subject.
Yeah.
Please go ahead.
So these are the services that we provide, as but most of the services which are what are the mandatory, all that we do, and at PHC level, at sub-center level, and there are also a lot of innovations that we bring in, like process innovations. Like, for example, there is a clerk in the PHC which we converted into administrator and brought a lot of changes because of that, without increasing the financial spending. And we a lot of programs we added, like mental health program we added, and eye care, like vision centers. We also de-addiction centers in the primary care, tribal A&M program, which I mentioned earlier, and a lot of IT, largest stream of supply chain management for our drug supplies. And we also used EMR, EHR, electronic health records and electronic medical records we brought into the primary care. And a lot of innovations. And ASHAs, when Government of India introduced, ASHAs were trained in 3 districts, and we could able to deploy and bring in a lot of inputs into ASHA program. And another important aspect of this partnership with community participation, VHNCs, Village Health Sanitation and Nutrition Committees, Arogya Raksha Samitis, Anganwadis, School Health Program, Panchayat Raj institutions, all are being involved in managing the primary health center. So these are some of the pictures of our technology. And we brought in traditional medicines into the system, and community planning and monitoring. And also we working in in Arunachal Pradesh. You can look at the before and after pictures when we are taking how the pharmacy looks and how the pharmacy and in the remote hilly areas of Arunachal Pradesh where infrastructure is very poor, doctors are staying in such quarters and very difficult to reach places, and the elephant on the back of the elephant, and and another important thing is quality. NABH accredited primary health center for the first time. Presently, I think this is the second NABH accredited primary health center in the country. And later government, we have insisted government to have a quality certification. NQS has come into place. Today, a lot of our primary health centers are NQS certified primary health centers. And this is the certification we got. These are the outcomes. A lot of health indicators have tremendously improved than the state average and the national average. Institutional deliveries have improved, and maternal mortality has come down. Infant mortality has come down from the beginning, and the other some of the one PSC I have just taken before taking over and after taking over. What are the issues and how we could able to change? And now presently in the partnership, as we were discussing in earlier presentation also, the partnership should be real partnership. The government is the spirit of partnership is missing over the years. Initially, when we started, actually, the participation of the government is very huge. Over the years, it is becoming more of outsourcing the work to a private partner or shirking the responsibility. And there is no monitoring and evaluation of the work done by us. And there is no real problem solving together. Because, there is no, especially rural and tribal health, there are huge issues at the ground level from the place to place. For example, South Karnataka, we have certain issues. North Karnataka, we have certain issues. In region-wise, we have issues. But how do you solve together? There is no dialogue between partners. Successful innovations, a lot of innovations were brought. For example, eye care, we brought Vision Center, we have incorporated into primary care. That scaling up is not happening. And there is no policy at the government level. How do you take a private partner into the system? So these are the issues. And so I will stop here. And these are the websites where give you some of the reports and outcomes of our partnership. A lot of people have done the research. IHMR had published, and PFI has published reports about our work. And I will keep this way forward a little open. The reason for that is actually it is not a very easy solution. I think with a lot of discussion only, way forward can come. With that, I think I will stop here and look forward for any discussion forward. Thank you.
Thanks very much, Venkat, for that excellent presentation. Trying to summarize 30 years in 30 slides is not easy. But I think we really got a hang of the difficulties and challenges. And despite that, you kept going for 30 years and not now even expanding from primary healthcare to getting to tertiary and to 10-bedded ICU, etc. is brilliant. Yeah, I mean, I think, can you just please stop sharing? And I'm glad that you put the way forward slide as blank one, because I think that's what we can discuss over next 10 minutes or so to see that what is really the way forward. And you hinted on certain things that the partnership is not what it used to be earlier, probably. So maybe, Rakesh, I would probably start from you. Over 10 minutes, I'll probably just try to guide some of this discussion and then followed up by questions that have been posed by the audience. I remembered that you had in your paper and in your subsequent paper, you talked about a model in Kerala for TB control called STEMS, where there appears to be more successful than others. And so could you elaborate that what was different there and how did that become more successful? Is there a greater trust between the partners, or is there a better management of the partnership? Are there better contracts, or is the private sector more enlightened in Kerala than in other states? Kerala is never a good example, by the way, because everybody says, but Kerala is different. But yet, I think we continue to look up to Kerala to find out some good practices. So please, uh, if you could
Yeah,
share a bit about
basically,
that.
basically it was about a model called STEPS. It is System for TB Elimination in Private Sector. So that has actually been evolved and implemented in Kerala. So basically, what makes it different is basically it is based on addressing the concerns of both private sector and the public sector. So that has been evolved basically with lots of consultations with the private sector. That is one key important thing. Lots of consultations, stakeholder workshops, everything happened to find out the problems that private sector is facing, and this has been evolved based on addressing all the concerns of the private sector. That's one thing. Second thing, it's a private sector led initiative. Private sector holds accountability also in that model. So there is an equal accountability. Government sector has their accountability, private sector has their accountability. Their roles are well defined basically. This is what government do, this is what private do. That's one thing. Second and third important thing is it is not something that has been actually been fit into. Basically, it has actually evolved as a solution to the problem. So basically, whenever we think of a public-private partnerships, we should never try to fit a ready-made solution as a public-private partnership model. So that we need to clearly define the problem, design the solution accordingly. Probably we'll get a good solution like steps basically. Another important feature of steps is there are mechanisms for dialogues. There are well-established systems like a private hospital consortiums are there in every district where the private sector, they have their elected representatives, they sit, they invite the government also regularly on a quarterly basis and dialogues happens. And this generally helps in making the building the trust sort of stuff. That's actually one of the another important feature. The most important striking feature is that patient is at the center of partnership basically here in the steps model. It's a patient centric model, and patient is at the center of the partnership. That's where when both the government and the private sector, they join their hands to ensure that what is good for the patient. So they generally, when we start discussing in that way, most of the problems will get resolved. So most important striking feature is that patient is at the center of partnership in that one. There is a good governance mechanisms. There is a data intelligence built into it to find out what is happening with related to all this sort of stuff. It's based on the solutions based on the design based on the problems, and there are mechanisms for dialogues. I feel this is something that has made that model a entirely different one. And now many states are actually trying to scale up this steps initiative, the principles, following the principles in many of the states.
Yeah. I hope that other states are able to, have a shift in mindsets, because I presume it's not only about having a set of systems or processes, but it's also about believing in equality. And also, I think it is in this case, probably a reciprocity and an initiative from either sides. So Venkat, I would, I'm glad to see that that Karnataka continues to manage a large number of PHCs. Of course, the numbers are probably somewhat lesser than what it used to be at the peak of at the largest number, but still there are very large numbers that you still manage across the different states. So, are there any differences across the states that you have seen in these partnerships? Are some governments more responsive? Some are less responsive? Because you remain the same across, I presume, it's the same organization. But when you partner with others, do you find that some partnerships work better than others? And what are those differences that you may want to?
Yeah, so like for example, in Orissa, we don't manage sub-centers. They give primary health centers only. Sub-centers are managed by by the CHC. And so that actually loses the focus. In fact, without community participation, PHCs loses its because the substantial amount of work is in the at the community level. And in the Northeast, again, there are issues about funding. Like 10%, they ask us to contribute for this partnership. Of course, we are contributing, but that is another difference. And here, like for example, in Karnataka, we have a clear-cut policy. there's a policy of a public-private partnership called Arogya Bandhu. Under that policy, who can be a partner, and that definition is there, but it is not in the case with the Orissa and the other places. There, it is more of RFE they publish, and who want to be participate, they can participate, and it is almost like a sort of bidding. There are different calculations to select a partner. So there are differences between state to state. But what happens is once we enter into the system, enter as a partner, we constantly keep a dialogue with the policymakers and try to streamline the system and try to change, what works and what should be the partnership. That's the reason why we are continuously with the different state governments. Like, for example, like we have already, completed 20 years in Arunachal Pradesh and 20 years in Orissa, which is very, very difficult to work that long without disruption and discontinuity. The differences between the state to state.
So, I mean, I think from my side, will be one last question from both of you. One to Venkat again. I mean, the point is that you seem to hint that over years it has become more difficult to manage partnerships with the government, right? So why would you continue to do it? Why don't you just provide services yourself? What value, the question is, what value do you see in partnering with government? Why not just, you started with a hospital in BR Hills, and then, but over 30 years, you continued to primarily work on this partnership model. So why, and even now with 10-unit ICU, etc., it's again a partnership with the government. Why would you want to, what value does it bring to you as an organization, in the sense that what value does it bring to the communities? Were you to do this alone versus working with the government?
No, it is, even though it is a difficult partnership, but there is a lot of value to this partnership. Like, we are able to bring in a lot of changes. We are able to, whatever the areas that we are able to bring in, what we are able to serve better, deliver the outcomes better, and bringing innovations which are sometimes are becoming mainstream. Like, for example, mental health was never part of the primary health care. Today it has become a part of a lot of advocacy. And NCDs in 2002, 2004, NCDs were not part of the primary health care. Today NCDs are part of the primary health care. We are slowly changing the government. So today, as I told in my presentation, that 90% of the primary health care is by government, and we cannot provide primary healthcare services without government. And government is the prime source, and partnership is the way to go if you want to strengthen the primary healthcare. And the only things to be changed is how do you
very clearly that that ultimately you can't do primary healthcare without the government. Bulk of primary care continues to be delivered by the government, whether there are partners or not. It is ultimately their mandate and the network and the resources. So Rakesh, a similar question to you, that why should government in Kerala, which is supposed to boast of the best public health system in the country, would want a private partnership? What value does private partnership bring to the government for the program? Why can't they just do it alone? You're on mute. You're on mute.
Yeah. With related to TB care, especially if you look at, 50% of the people are receiving care from the private sector. That's something which is true, even in Kerala. So if the government is committed to the people, and if they want to ensure that standards of TB care is, all citizens receive standards of TB care, everybody getting treatment adherence support, everybody is completing their treatment. Obviously, yes, it's actually a great opportunity to partner with the private sector, because 50% of the people are reaching the private sector. So they can actually help in government's vision of providing standards of TB care to all citizens, reaching them, and that will eventually help in benefiting the society, basically. So obviously, as they say, it's a huge opportunity to partner with the private sector for the citizens. Again, what I always try to say is public-private partnership is finally for the benefit of the society. So that's what government has to provide here.
Great. Thank you very much. I think it is absolutely clear. The few things that are clear to me from this conversation is that it is important to do partnerships in healthcare, right? I mean, whether it is with not-for-profit organizations, or with private sector which is proactive and is one of the statements that I was struck from the first finding that you shared, Rakesh, was that private sector in general, almost everybody said that we are interested in doing something, but it needs to be equal. It needs to be based on trust. It should not affect their, practice adversely. Similarly, Venkat, you're saying that primary healthcare is delivered primarily by the government is again a very significant one. So I think these two things put together put the whole partnership things in context. You need government to deliver it and to lead it and to steward it, but you need partnerships to take it to the last mile, to build on their reach of the non-governmental sector as well. So, and the last kind of insight that I'm getting out of it is that these partnerships do significantly better than when you're working alone. Either the government alone or the non-government, even the NGOs working alone. From Corona Trust experience, that it is significantly better when you work together. So with these words, I will kind of stop here and will request Veda to take on some of the questions that have been raised by the audience.
Thank you, Purple. Thank you, Dr. Rakesh and Mr. Venkat. So we have received questions on multiple dimensions about the PPP. One dimension that's kind of interesting is about the community, right? So this question is both for you, Dr. Rakesh, as well as Mr. Venkat, is around, what are your insights in terms of the acceptability of a private-public partnership from the community, right? So Dr. Rakesh, you spoke about the privacy part of it, where people are not willing to, for their information to be revealed. On the other hand, I would also then go to Venkat to talk about what is the acceptability of remote regions of Northeast. That's a question that someone has asked about the acceptability of PPP in this area. So over to you, Dr. Rakesh.
Yeah, again, what I always insist on saying that all partnerships need to be patient-centric or citizen-centric. Citizens need to be at the center of the partnerships. Partnership need to be designed around the citizens, basically, or around the public need. And whatever is, ultimately, they are going to be the beneficiaries. The beneficiaries of the partnerships are the citizens. So they are the key stakeholders. We need to think of them. We need to involve them while designing the partnerships. We need to assess their need and design strategies accordingly. This is what I would suggest.
So the community engagement in the primary healthcare service delivery is very high, and especially in our Corona Trust managed primary health center, the whole process start with the community participation and community engagement. And in fact, some of the requests comes from the community to be, because they know, they have seen, they heard that the primary health center run by Corona Trust are well service delivered. They come to our office and requested for partnership. And also, there are instances where government wants to terminate the partnership, where the community has requested the government. In fact, some places they agitated against the government that the partnership should continue. And there are instances where government was not releasing the salaries 6 months, sometimes 1 year. There are instances where community pooled the money together and paid the salaries. So it is that kind of participation by the community, and it is very high level of acceptance by the community, because they are getting the services and they are able to see nearby primary health center, how they are functioning, how the primary health center run by the private partner, how they are functioning. So there is a huge acceptance.
Excellent.
Thank you.
Thank you. Another question that has come up is around the learnings from such public-private partnerships. So, what would be like the long-term and short-term objectives of how the learnings from such partnership can be used for the future?
see, that's one thing which actually should be way forward. I kept that the slide way forward. In fact, the lot of innovations, a lot of process innovations, program innovations, which are private player brings in, it will not go beyond a certain area. Like, for example, wherever Corona Trust is managing, to the how can you do that? That is only can do with a structured dialogue, structured monitoring and evaluation, and where you are able to perform well, how, how you are able to perform well. Suppose if I'm conducting 10 deliveries in a month in a primary health center, in the next primary health center, which is run by government, is only doing 2 deliveries. What is the difference? Why? So these structured dialogues and outcome sharing and process dialogue is very important. With that, either short term or long term will be achieved long. In fact, it is a proper partnership which will be able to manage, and also we can keep the targets. So, like for example, the high prevalence of leprosy in Elando, which has a target, we eliminated leprosy in that area. So that is how the partnership should be structured. So that is way forward, which I look forward.
Thank you, Sir Venkat. So one of the questions is around, looking at the motives of the private sector. Typically, if you look at public-private partnership, it's with NGOs and where the goal is aligned with the government entity. But in case there are for-profit organizations which are willing to be interested in this public-private partnership, then how do you strike a balance at the same time by also protecting the right of the community for health and whatever is the goal of the project? So, Dr. Rakesh.
Yeah. So basically, again, this partnership is a process. We do not consider that as an outcome generally. So whenever we are building the process, we need to have a very clear outcomes and monitoring mechanisms. Again, partnerships, they are very broad terms. It can even start from engagement of, say, simple engagement, informal collaborations to more sort of structured partnerships with MOU sort of stuff. If that is the kind of partnerships that we are actually looking at, they need to be clear monitoring mechanisms, clear systems in place. There need to be what I would suggest is basically a joint review systems or clear monitoring. I mean, there need to be a mutually agreeable body who could actually monitor this sort of stuff throughout, including that. So that will actually help in creating. Again, that partnership need to be formed only when there is an actual need. So again, partnership is not for the benefit of the government or for the private. Ultimate beneficiary, it will be the society.
Yeah, my answer for this is more if you formulate the policy very clearly, the most of the issues can be resolved. That today we do not have very clear-cut policy on public-private partnership, and who is your partner, who should be your partner, and how the partner is selected, how the partner interests are safeguarded. Everything you can brainstorm and think thoroughly and put it on paper, and allow it to also for corrections during the whole partnership. Because let's say Corona Trust now for 30 years we are partnering with government. There are a lot of changes happened over the years, but stick to one particular policy. That, I think a lot of issues can be resolved with the policy formulation.
Thank you, Mr. Venkat. So looking at the time, so I hand it over now to Pavitra to summarize our discussions from this session.
Thanks. That's a difficult task to summarize, such a wide area of work, as well as such, long experience and, evidence from multiple places and the discussion that ensued. But I would just maybe try to, say a few things that I'll carry with me, and I hope that's that will be probably summarize some of the key learnings from the session. The first, I think I'm even more convinced after this session that it is important to have partnerships in healthcare. It is important for government to lead the partnerships, but also to be forged partnerships with non-governmental entities that lead to effective delivery of primary healthcare services and public health programs. So I'm even more convinced of the value of it. So that would be one part. The second, I think, just the point that Venkat made in re-emphasizing that the government needs to be delivering primary healthcare. It does deliver bulk of primary healthcare even now, but it needs partners to deliver it effectively, especially for complex problems and in difficult areas. I'll also take what Rakesh said, that ultimately people need to be at the center of these partnerships, and the problem needs to be at the center of the partnership, right? I mean, it is not public-private partnership is a tool. Ultimately, it can. What is it for? What problems are we trying to solve? Are we trying to solve the problem of delivering healthcare to the last mile communities? Are we solving the problem of community participation, or are we creating an ecosystem for innovations in primary healthcare? And if we start with that, that's where it will remain centered. Somebody also mentioned in the comments that where is the public? I mean, how do you ensure that people are at the center? And I think it is by design that if from the beginning it is people are at the center and the problem that people are facing in accessing healthcare is a problem, then probably design something. These on a more kind of a nut and bolt thing, what Venkat said about having clear contractual mechanisms and clear policies. The states which seem to have, like Karnataka, which seems to have clear policy, which have withstood the change in political kind of who's leading the state at the center. It is probably, from what I understood, has withstood that. There is a policy that is clear, and therefore that helps in ensuring that you have the right partner, the partners are clear. And largely, I think, lastly, I would say that the mindsets are really important. Having that mindset of equality, of respect for each other as partners, and bringing in, starting from a position of trust, but also having clear policies and guidelines. There have been some questions or concerns or comments about the evaluation and audit of some of these partnerships, which I think, again, if you start with a problem and there is a clear pathway, then some of those things are taken care of. But I think if we have to begin with a position of trust and having clear guidelines for identifying the right partners and working with them over the time period. The other thing that I took from what Rakesh said, that these partnerships are a process. It's not that you do all of it at the same time. It takes time to build them up and to follow them up over longer periods of period. But I think lastly, the message that I would at least like to carry is that because it is so critical to have these partnerships, we have to put our heads together to identify what is the right way to help the government as well as non-government entities to take these partnerships ahead for the sake of people of the country, right? I mean, ultimately, there are large areas where marginalized populations, people with specific diseases, or areas with absolute inaccess to healthcare, and these partnerships can help bridge that gap if we put all our minds and efforts together across the organizations, across the sectors, and across the states, and not be restricted to our own silos of working in specific kind of areas. So with that, I'd like to thank the panelists again. I think Venkat and Rakesh, you bring such enormous amount of insights and experience and evidence from long years of working in such difficult and critical areas. So thank you very much, and thanks to all the audience for sticking on a Friday evening. So back to Veda for the final. Thank you.
Thank you, Professor.
Some of your work, but sorry.
No problem. So, yeah, a program and people-focused PPP with a clear policy guiding it, with the mindset of respectful and equal partnership. They seem to be what we have gathered today as the important things to keep PPP going. I want to take this opportunity to thank Dr. Rakesh and Dr. Mr. Venkat for joining us in today's edition of Dialogue Series. I also want to thank all our audience who have tuned in today. We shall be back with another episode very soon. Stay tuned. Thank you.